Okay. Hello class. Last time I was talking about abdominal trauma. I don't know if I don't remember if I had spoken to you about damage control surgery. Damage control surgery is very important. I remember I spoke to you about abdominal compartment syndrome, but damage control surgery I don't remember if I had spoken. So I'll be talking about damage control surgery, and then I'll move to retroperitoneal and the miscellaneous topics. First is, what is damage control surgery? When you have a lot of injuries and the patient is about to collapse, so you will do one particular surgery so that you will save the patient, followed by you resuscitate the patient and do a second surgery that is needed to help the patient out. So this is damage control surgery. So initial evaluation, you do a damage control surgery. If it is a liver trauma, you will pack the liver. As I told you, that's the treatment. How do you do? And then if it's a splenic trauma, you will do a splenectomy, followed by other injuries you would take care of, that is fractured bones or other things. So damage control surgery is done within 24 hours. We will try to stop the bleeding or whatever is there. That is damage control. So the first part of the surgery you do, and then you resuscitate the patient for the next 48 to 72 hours. And this 72 hours, you have to remember one particular point that is called as deadly triad. It's called as deadly triad. Deadly triad is nothing but, it is acidosis, coagulopathy, and hypothermia. These are the things that you resuscitate the patient in ICU setup, probably with a ventilator, and then you slowly wean off the patient of it, that is from the next 48 to 72 hours, and once you cross the 72-hour period, you will do what you call as the main surgery, or the surgery that you're intending to do, like the bone repair, like the bone repairs, the muscle repairs, the tendon repairs, or any other trauma that is less dangerous than the surgery you had performed on the day one. So damage control surgery on the first day, followed by resuscitation, and then you do the main surgery, the accessory surgeries, once you settle the patient in. So what is the deadly triad? Coagulopathy, hypothermia, and metabolic acidosis. These are the deadly triad. The patient has to come out of it. That will take about 24 to 72 hours. Once after the 72 hours, you will plan a surgery that is needed for the patient's betterment or improving the patient further. So this is about damage control surgery. Most often it is in the abdomen and the thorax that we do, and followed by we will do. Then you have retroperitoneal injuries. So what are the main structures that you see in the retroperitoneum? Yes, number one is pancreas, number two is the kidneys, number three is the colon, especially the descending colon, then descending and the transverse colon, and then little part of the transverse colon and the descending colon, especially at the splenic hilum, at the splenic flexure and below, and the vascular structures. The most important of it is IVC, as well as IVC is inferior vena cava, and also your abdominal aorta. Is that clear? These are the structures that you will be checking in case of retroperitoneum. Now, each of it we should be discussing and how you handle each of it. After which we will discuss about blast injuries. Then we will discuss about missile injury if it is there. Then we will discuss about I told you last time that I'll be discussing about the trauma evaluation scores. There are 3 of them that are important for you. Then I'll be talking about 2-3 important aspects of the upper limb extremities and lower limb extremities, and then I'll check about and see what else I need to be talking about. So these are the things. First and the foremost is the pancreatic trauma. Pancreatic trauma is quite important. Most of the times it is the seatbelt injury when the mesenteric tear is there, or a blunt trauma abdomen, when you have pancreatic injury. And the penetrating injury can also cause this thing. Whenever you have a seat belt mark on the body of a patient who has come to you, it is an indication that you do a laparotomy or a diagnostic laparoscopy to rule out anything of damage in it. So pancreatic trauma is always not, it's going to be one. It is also going to be a trauma at the duodenum part 2, which is because they're almost in continuity. So you have to remember that pancreatic injuries are not going to be alone. First, you should see for a mesenteric tear. Second, you should see for a pancreatic injury. Third, you should see for a duodenal tear. These are the three things that you will be checking about the seat belt injuries or penetrating trauma, gun wound, as well as blunt trauma abdomen. Now let us see what we are going to do. You have great pancreatic trauma. 1, 2, 3, 4, 5. All of these are 1, 2, 3, 4, 5. Please remember 1, 2, 3, 4, 5. In the first place, it's only a contusion. It's only a contusion, subcapsular hematoma of the pancreas. Okay. Then 2 is less than 1 centimeter laceration, and subcapsular hematoma with contusion of size greater than 25%. Third grade is only laceration of greater than 1 centimeter with distal pancreatic duct injury. If it is 4, it is laceration with proximal duct injury, and if it is stage 5, the head of the pancreas with ample of water, complete disruption. That is the 5 stages of pancreatic trauma. Why is pancreatic trauma so important? Because pancreatic trauma, once injured, will leak what you call pancreatic juice, which in itself is such a bad irritant, and the damage that it is going to cause is so huge. Pancreatic injury itself is a big problem because it's extremely painful, high vascular supply, and near to just at the first part at the end of the pancreas. Beyond are the important and vital structures of the portal vein, IVC, and the aorta. So pancreatic trauma is so important. So what is the diagnostic tool of choice? You don't get them on ultrasound or fast. You should be thinking about a CECT abdomen. Very important. Pancreatic injury investigation of choice is pancreatic CECT abdomen. Please remember this. And once you have diagnosed what is the injury, amylase and lipase are of little to no use. So when there was a bit, I don't know if it is going to be asked now, that what are the things, what is the investigating point? So they will say amylase and lipase rise. No, amylase and lipase do not rise, or they are not specific at all in case of pancreatic injury. Then once you have this diagnosed, what would you do? What you have to do? You have to do a laparotomy. You have to check for all the things I told that can be getting damaged in a seatbelt injury or a penetrating trauma, whatever. When it is first 2, you can wait and watch. The first 2 stages less than 1 centimeter without any duct injury, and then only subcapsular hematoma with contusion. You don't have to operate. You can wait and watch. Whereas if you have 3, 4 and 5, probably you have to open up. When you have a distal injury of the laceration, what you can do is you can just do a pancreatico-jejunostomy. If proximal injury is there, you have to do a pylorus sparing Whipple's procedure. Okay, you have to save the pylorus by doing a Whipple's. Pylorus sparing. In Whipple's, usually you do a pylorus excision of pyloric antrum. In this, you don't have to do this. You don't have to do. And when it is ampulla with head of the neck, you have to do a total Whipple's procedure, total pancreatectomy with a complete Whipple's. Okay, that is gastrojejunostomy, pancreaticojejunostomy, gastrojejunostomy, and CBD to jejunostomy, jejunostomy from the CBD to the jejunum. These are the things that you're going to perform in a case of pancreatic injury that is involving the head of the pancreas. So investigation of choice, what are the three stages of this? Third stage, fourth stage and fifth stage are the ones where you do a laparotomy and then check about it. And usually pancreatic injury carries relatively bad prognosis. Not a great this thing, but it carries relatively bad prognosis. Once this is done, then you will move down to manage. That is how you manage. Then we'll move to the other retroperitoneal structures, that is kidney. Most of the times it is single kidney that is injured. Bilateral is possible, that it does not mean that it is not possible. Bilateral is possible, but what it is. So when a kidney is injured, how will you know? In the first stage, it is only contusion and subcapsular hematoma. Okay, again it is blunt trauma abdomen, arterial traffic accidents. This is where the kidneys get injured. So what will happen? You will have the first stage is contusion or subcapsular hematoma less than 10%, laceration of 1 centimeter, and subcapsular hematoma greater than 25 percentage with contusion is stage 2. Stage 3 is a laceration that is more than 1 centimeter, less than 3 centimeters with cortical injury. Stage 4 is your injury to the parenchyma, okay, renal parenchyma, cortex, okay, and with vascular injury, that is the main renal artery and vein injury with controlled hematoma, that is the bleeding has been controlled by the body itself. And when there is vascular pedicle disruption and evulsion of the kidney, that is stage 5. 1, 2, 3, you can wait and watch, and then 4 and 5, you need to do a procedure. You have to open up and see what exactly is happening. So what are the symptoms the patient will present with? Number 1 is hematuria. Please remember, hematuria. Presentation is hematuria, not anuria. It is hematuria. Presentation is hematuria, retroperitoneal pain in the loins, then patient is in shock if the bleeding is massive, because involvement of the main renal vessels, that is renal vein and artery, will cause this thing, will cause damage, that is hematuria. So you have to see, then you have to open up, and based on the need, you may have to do the bleeding surgery with placement of a stent. This is done. Then what will happen? Do you remember anybody knows about pubentral injury and bladder injury? Most of the times bladder injuries are seen in pelvic fractures, road traffic accidents. So what happens in this? The bladder is ruptured. The patient is not putting any urine. So what will happen? Because the urine is getting extravasated into the abdominal cavity. So it becomes imperative for you to operate immediately. Put a bilateral suture with Vicryl. You use Vicryl or polydioxazine. These are the two structures that, these are the two suture technique that you're going to use for bladder injury, and it is repaired in a double layered closure, okay, and you will put a Foley's inside, and retain it for 14 to 21 days. That is again opening and laparotomy. How do you know it's a urethral injury? Whenever you have a road traffic accident, with a pelvic trauma, if there is a bleed, Okay, if there is a bleed in the glans penis, near urethral opening of the glans penis, it is to your mind that the patient is probably having a urethral injury. So what would you do? You will never put a Foley's catheter. Initially, you will put a suprapubic cystostomy. Once you put this suprapubic cystostomy, then you may have to repair the urethra. But if you put a Foley's, please remember, you will not remove the Foley's. The Foley's has to be retained for the next 14 to 21 days, irrespective of what. And suprapubic cystostomy that you put for urethral injury also needs to be put in will have to be retained for 14 to 21 days. That is about the kidney, that is about the bladder, and that is about the urethra. Single most indication of not putting a Foley's during pelvic trauma is presence of blood at the ureterohiatal opening in the glans. This is an entrance pit. So many times it has been asked. You should not be putting a Foley's. Whenever you see a blood at the tip of the urethra. Okay, is that clear? You will not be putting a Foley's. No question of putting a Foley's. That is about this. Then the other structure that is important in case of pelvic trauma is the vascular structures. Whenever you have an abdominal aorta injury, it is imperative for you to open and close it. And whenever you are closing the abdominal aorta, you have to remember two things. Number one, you have to cut the edges to sharpen them, close them, and put a PTFE graft. Okay, PTFE graft, it's like a mesh over the closed area. And you will use a non-absorbable suture. That is PTFE graft, you should remember. Non-absorbable suture material is 50 or 60 polypropylene suture material. And the bigger problem for us is repairing a venous injury. Very, very, very important. Why? Because the more you try to suture the vein, the more problem is thrombus formation because of the low pressure that is present in your venous column. So the low blood pressure will lead to formation of thrombus. That is more dangerous. You close the IVC and you have this thing, then hematoma that will form a thrombus, and this thrombus can lead to a dislodgement and can produce pulmonary thromboembolism or a cerebrovascular attack. So what is the biggest problem with suturing of a vein is your thrombus formation. Why? Because the blood column is slow moving because of the low blood pressure. Okay, low blood pressure, and the viscosity of the blood, that is deoxygenated blood, is little higher. So it helps in formation of the thrombus. So it's more observing a venous injury with compression is more important than suturing a venous injury. So now we will come to the three system scores that we have. These are called as the newer methods of evaluating the trauma. So these are called as revised trauma score, RTS. Then you have TRISS, TRISS, and then MESS. These are the three systems that you should be remembering. RTS, revised trauma score, is nothing but respiratory rate, type, a blood pressure cuff and check blood pressure, BP, respiratory rate, and last thing is RTS, S is shock. I mean, that's what you're going to check. Revised trauma score. Then you have specific injury also in S. Then you have TRIS. In TRIS, RT is RTS. That is your revised trauma score. Okay, number one. Then you have injury severity score. Injury severity score. That is R is RT. Revised trauma score. I is injury severity score. S is scene age of the patient. Scene age of the patient. And S, under S is specific injury that you want to get. These are the four parts of TRIS. Revised trauma score, TRIS, and then MES. In MES, the main energy that is causing injury, M, the main energy that is causing injury. Then E, external ischemia. External, E stands for external ischemia. S stands for scene age of the patient again. Scene age of the patient again. And S, another S is shock. Another S is shock. These are the four components of MES. MES is main energy that is causing injury, extremity ischemia. S stands for specific scene age of the patient, and another S stands for shock. Whereas in TRIS, RT, that is revised trauma score, injury specific score, scene age of the patient, and specific injury. RTS, that is revised trauma score, your blood pressure, followed by your BP, and then S is for shock. These are the three different trauma scores that we are following of late, the latest way. And S in RTS stands for Glasgow Coma Scale. Glasgow Coma Scale. Yeah, that is what shock in Glasgow, GCS. That is revised trauma score. Then you have TRIS, where is RTS, that is first two words stand for revised trauma score. Then the next I stands for injury specific score. Scene age, one S is scene age, and another S is the specific injury that has brought about to the patient. And then you have MES, that is the main energy that is causing the trauma. Number two is penetrating injury, or number two is ME, extremity ischemia. S stands for scene age of the patient, and another S stands for shock. Another S stands for shock. This is about the trauma scores that we are usually following to check about with the patients who have come with trauma. So these are the three. Remember, you have to remember the three, that is RTS, revised trauma score, that is respiratory rate. T stands for your blood pressure, and S stands for Glasgow Coma Scale. Then you have TRIS, wherein first TR is RT, that is revised trauma score, injury specific score, injury severity score. And then you have S, scene age of the patient, and last S stands for specific cause of the injury, that is penetrating or blunt trauma. Then you come to the MES. MES is the mechanical injury that has caused, mechanism of injury. ME. E stands for extremity ischemia. S stands for scene age of the patient, and another S stands for shock. Then you have trauma with the extremities. These are the two important points that you have to remember. That is, as you have abdominal compartment syndrome, the same thing in trauma, you will have compartment syndrome of the limbs. Whenever there is an injury to the femur or the tibia, the blood extravasation can lead to formation of compartment syndrome. If it is a supracondylar fracture of the humerus, you will have compartment syndrome of the upper limb, because of the bleed that will extravasate and cause edema and increase pressure in this thing. If remember this number, greater than 30 millimeters of mercury, you have to do fasciotomy. In greater than 30 millimeters of mercury pressure in compartment syndrome, you will have to do a fasciotomy. The word is important. If you use the word fasciotomy, that is when your theory marks you will get. You have to do a fasciotomy. And And if you don't do fasciotomy, in the upper limb especially, you will develop something called as Volkmann's ischemic contracture. What is that? Volkmann's ischemic contracture. Volkmann's ischemic contracture is nothing but whenever you have the compartment syndrome of the limb, the upper limb especially, the muscles die. So the patient presents with severe pain in compartment syndrome. That is called as cry of the dying muscles. It is compartment syndrome, cry of the dying muscles. Cry of the dying nerves is seen in Burgess disease. I already told you. Cry of the dying muscles is seen in compartment syndrome of the upper limbs or the limbs for that matter in general. So these muscles are causing severe pain because they're going into ischemia. And if you don't do a fasciotomy and relieve the pressure, what will happen is the patient will go into something called as Volkmann's ischemic contracture. The whole limb will go into contracture and the patient will develop a full claw hand, and you will be able to do nothing, and ultimately the patient will end up losing that. I mean, you may not have to do an amputation, but the patient may end up with this thing. Now then we'll come to blast injury. Blast injury is nothing but whenever you have a major explosion, a terrorist attack, or dynamite that is used for quarries where you can get the stones. If anybody is there. So what happens in this blast injury? The blast injuries, the problem is what happens? How will the patient have? The patient is not going to have only one injury. The patient will have because of 4 types of injuries that he'll develop. That is primary, secondary, tertiary, and quaternary. In primary, it is because of the blast pressure. Okay, it's because of the blast pressure that the patient falls apart. Okay, that is blast pressure. Number 2 is the fragments of the blast segment penetrate. That is secondary blast injury. Tertiary blast injury is the blast flames causing injuries. And last quaternary is when the patient goes and hits himself to some other structure. Injury because of that, blood traumas are caused by blasts. So they are primarily divided, they are divided into 4 states. That is, one is because of primary, secondary, tertiary and quaternary. In primary, it is because of the blast wave that is causing the injury. Number 2 is the fragments piercing and penetrating. Number 3 is flames and because of a lot of carbon dioxide, the breathing problem, that is number 3. And 4 is because of the blast wave, he moves and hits something else, and that particular thing causes problem to the patient. That is what is called as blast injuries. So whenever this patient comes, your first and the foremost thing is separate the patient from all the things that is there, that are around. So you have to remove his dress, whatever. Do a quick primary, secondary survey, as I told you initially in the trauma, and then here also we have to see about the damage control surgery, because the fragments are going to be inside. So you have to remove the fragments and leave the wound open for a closure after 5 to 7 days. That is called as delayed primary closure. This is important. This delayed primary closure is an entrance question. Here I want to tell you, every year, I'm not talking about every year, there is an entrance bit coming from the types of wound healing: primary closure, secondary closure, delayed primary closure, type of this thing like clean surgeries, unclean surgeries. What are the type of surgeries? So whenever there is contamination, it becomes this thing. So appendectomy is a clean contaminated surgery, whereas perforation is a contaminated surgery. Okay, intestinal obstruction that got perforated is a contaminated surgery. Clean surgery is a thyroid hernia. The chances of these getting infected are rare. Whereas the clean contaminated wound, the chances of infection are little high, and contaminated wound, there is always a chance that the patient will get infected. So drain becomes compulsory. Closure depends on the doctor's decision. Types of wounds and wound healing. Without a question in this 5-6 odd topics, there is no entrance paper. No entrance paper, trust me. Types of wounds, number 1, and wound healing. Without these things, there is no entrance question. Please remember, please remember, there is no question that you skip what are the types of wounds and what are the types of healing. No question that you skip, because they are repeatedly, every year on a yearly basis, there is a question on this. So general surgery, high yielding topics is wound healing and wounds, type of wounds and wound healing. The first topic that we teach you in your third semester, which you hardly must have come to the classes, is wound healing and ulcer, and without question each of malignancies in ulcers and wound healing and wounds, there is no entrance paper. No. Every year there is a question on this. You will, I'm telling you, because you guys have missed so many classes, you will repent. Why? Because these are not the things that you will study and get them. These are not the things that you will study and get them. You should actually understand what is the wound, what is the type of wound, and how it will heal. This you will read. No book, I tell you, has given you what is this wound, and this would you would have actually learned only in a class. But unfortunately, Medicity is so famous for students not coming to the class. Can't really help. Then what are the things that we are missing? I'll just see, and then we'll cover the rest of the things. Yeah, I forgot about it. The most important, that is your diaphragmatic trauma. So, what is diaphragmatic trauma? When do you call it as diaphragmatic injury? When do you suspect diaphragmatic injury? The problem is we usually do not suspect. And that is where the problem arises. So, what is the most common type where you get diaphragmatic injury? It is penetrating trauma of the abdomen. So, where do you see diaphragmatic trauma? Diaphragmatic trauma you see when there is a penetrating injury. So, there is something called as Begg-West triad. Okay, a Begg-West triad. Please remember Begg-West triad. In Begg-West triad, you have the third part is the diaphragmatic injury, fracture lower ribs, and a pelvic or a spinal injury. This is called as Begg-West triad. Diaphragmatic injury is a must. That is the third component. Number 2 is the spinal injury or pelvic fracture, and number 1 is fracture ribs. This is the time when you have the chances of having a high level of diaphragmatic injury. Usually we miss this, okay? And always diaphragmatic injuries need to be operated. Imperative of nothing, they have to be operated. And how will you diagnose? You should have a high degree of suspicion. That is when you will do this. So how do you diagnose a diaphragmatic injury? You have to pass a Ryle's tube. Then you send a dye, that is barium or anything of your choice, and then take an X-ray. Okay, contrast X-ray you take, and that is when you find that the stomach with the Ryle's tube is in the chest. Then you have no other option but open and do a surgery. So investigation of choice is X-ray with a Ryle's tube, a contrast X-ray with a Ryle's tube. This is the investigation that you should be doing for diaphragmatic injury, and it is always imperative. But the investigation of the gold standard investigation is VATS, video assisted thoracoscopy. Video assisted thoracoscopy for diaphragmatic injury. Whenever you suspect a diaphragmatic injury, it is important that you check the patient with VATS, which is not possible. And the next investigation that I said you is contrast enhanced image study, that is your contrast enhanced X-ray with a Riles tubing. And once you see the contents here, there is no other option but you do. When you do VATS, the important is you can do a repair. Video assisted thoracoscopy, you can actually repair. So VATS is the gold standard because you can operate, whereas with contrast only you can identify, not operate. So that becomes gold standard. But investigation modality is this one. When both are there, you choose VATS. When VATS is not there, then you will do a contrast enhanced this thing. That's over. Diaphragmatic injury, I already spoke to you about flail chest, seat belt injury. Yeah. Then you have to remember about vascular injury of the lower limbs. Vascular injuries of the lower limb. So there are three parts in the vascular injuries of the lower limb. Whenever there is a vascular injury to the lower limb, the chances are it is going to make the limb bad. Whether it may cause gangrene, it may cause an impending gangrene, or it can cause severe this thing. So first and the foremost is it's called a dead limb. Gangrene, whenever is present, it's a dead limb. You can do nothing. Then you have a deadly limb. Wherein in deadly limb, wet gangrene, number one, spreading cellulitis, and atriovenous fistula. This is deadly limb. All these are entrance questions. All these: dead limb, deadly limb, and dead loss limb. Severe rest pain, dead loss limb. Dead limb, deadly limb, dead loss limb. In dead loss limb, you will not have a full problematic lower limb, but you will impending gangrene is there. So the patient will have rest pain. The patient has paralysis, and then he will have a contracture. Dead loss. Dead loss is the limb is almost gone. It is not working anymore. So when it is not working, it is no use. So it becomes a dead loss limb, but still the limb is limb that is present. So dead loss limb is any day better than a dead limb or a deadly limb. In a dead limb, you have to go for amputation. You have to go for amputation. In a deadly limb, you can salvage. You can salvage the limb most of the times. And dead loss limb, it is chronic wound. So there is nothing much you or I or anybody can do. That's over. Then I already told you how do you repair. You do a interposition graft with end-to-end anastomosis. I told you veins are difficult to repair because it causes thrombosis. I told you about the seat belt injury. I told you about diaphragmatic injury. I have told you about a blast. Yeah, in blast injury, I really forgot to tell you, this is very, very, very important. What is the most common organ to get injured in a blast, in a blast setup? The first and the foremost, please remember, hollow structures are going to get damaged in blast, the first primary thing. So the most common organ that gets injured in a blast injury is tympanic membrane. This has been asked numerous times. Tympanic membrane is the first organ to get damaged in a case of blast injury, followed by the upper airways and then the small intestines. So tympanic membrane followed by air-filled lungs, and number three is your small intestine. Whenever you have when you drown, the most common organ that is getting injured again is your tympanic membrane, followed by your intestines. When it is drowning, intestines, first is tympanic membrane, followed by intestines. When it is blast, it is tympanic membrane, followed by your lungs, and that follows your intestines. Please remember all these. Yes. Then what else did I miss? I already told you about the deadly triad. Phase 1, phase 2 and phase 3 of this thing is done. Seat belt is done. Management of missile injuries. The last thing that we will be discussing is one, spinal cord injuries and sources of repair. Yeah, this is somewhat, it's not for you, but I don't know, it is always asked for undergraduates. So whenever there is a severe hand trauma or almost amputated, how do you repair? How do you repair? So you should remember, the first thing that you will repair is the bone. The first thing you will repair is the bone, followed by the extensor tendon, then followed by the flexor tendon, Please remember, in this, they ask you in this, what is the sequence of order of repair of hand injuries especially. So first thing is the bone, followed by extensor tendon, then you close the flexor tendon, then you will close the vascular, that is artery, followed by nerve, and then vein, artery, nerve, vein, then you will close the skin. So what is the sequence that you follow? First the bone, then the extensor tendon, then the flexor tendon, artery, nerve, vein, and then the skin and the subcutaneous tissue or the wound closure. Please remember, bone, extensor, flexor, artery, nerve, vein, and the skin subcutaneous tissue. And I already told you about in my previous classes on shock. I remember I told you, whenever there is a spinal cord injury, patient will have continuous hypotension. This is normovolemic. The patient is normovolemic. He is having, because of increased venous capacitance, and that is because of increased venous capacitance, that is because of neurogenic shock. So what happens here? What happens is that the patient will have a neurogenic shock, whereas the increased venous capacitance and his blood pressure is not shooting up. He'll have a persistent hypotension, and the inotrope of choice here is phenylephrine followed by your vasopressin. These are the two drugs that you have to remember in neurogenic shock, that is vasopressin as well as this thing, Deglin, Bendlosilim. These are the three things you have to remember, and I'll see if there is anything else. Volkmann's ischemic contracture over. Last injury is over. Yes, now I'm going to take the questions. With this, I have completed trauma. Trauma is important for theory point of view. Trauma is important for entrance point of view. Entrance, it's a 5-star. Without a question from the topic trauma, there is no entrance question. Yeah, I'm opening the YouTube and hopefully you will ask questions. Let me see how many of you are hearing first. That's live stream. Only 11 of you watching. What should I do with you guys? Seriously? That's live stream. Only 11 of you watching. What should I do with you guys? Seriously? That's live stream. Only 11 of you watching. Mera Abhijit, tu 40 से ज़्यादा class करते हो? I'm not giving you attendance. All those 230 plus. No. Anybody has any questions, please? You can ask. Anybody has questions? You can ask. All those 11 of you who are watching. Abhijit is not even replying, which means he just put his attendance and left. Era Sai Krishna, Nike Mahindra. What happened to you? Nimisha, Shriya, what is this? What is the timings that you're coming on online? Huh? Horrible, horrible. Any questions till now? Hi and Abhijit, see. Ochinde purra 2:42 ki. Na class aipoye time ki. Okay, anyways, what are the questions? With this, I have completed trauma. I have completed the arterial, venous and lymphatic system. I have completed hernia. All these are, I'm telling you, I don't think even your people who are taking classes for entrance will also cover so many points, minute points that have been asked right from 1985. I'm searching them and getting it for you, and when I see only about 11 of you in the class, it is pity. I should also start preparing the charts and talk whatever is there in the chart and get lost. That is how I think I should be doing it. This is getting ridiculous. I don't think I can seriously change people of Medicity. Shame on you guys. You are never going to learn and you will suffer, I'm telling you. You guys are going to suffer in your post-graduation, everywhere in your life. I'm telling you, you will make poor doctors. Poor doctors, not at all good. And you will be fit as becoming tutors or assistant professors in some college. You will not have good practice. I'm sorry to say this. Sorry to say. Absolutely ridiculous. What is this? All of you give your attendance and get lost. Why do we have to take any classes for you? Why do we have to? I'm searching something from 1985, all the questions that are coming, and trying to tell you, and you guys are hardly watching or listening to. God knows what discipline you have and what you're going to do. You're going to suffer. I'm telling you, you are going to suffer. It is none of my business, but it is high time that you seriously change your stance. The world outside is so damn competitive. So damn competitive. Good knowledge, you're nothing. Imagine with your level of discipline and knowledge, you will be dogs. Trust me. You'll be going to dogs. You cannot really become good. Some of you, yes, every batch will have about 10 people who are extraordinary and they will definitely become successful. There are about 10 who are extraordinarily talented and about 10 who are almost going to be successful. What about the rest of the 80, 70? Hardly, I mean, I'm just getting irritated with you guys already. I'm telling you, I'm seriously observing everything. I'll definitely give you only about 35% of internal marks. I'm telling you before. I'm not going to allow sir to give you any extra. If you're failing because of it, I'm not bothered. Because when you are indisciplined, what will we do? I'm signing off.